There is a patient in your ICU, perfectly stable, improving and about to discharge. But next day, patient develops DVT and also Foley's catheter related infection. Now, what went wrong? The answer is simple. In the ICU, patient deteriorates not only because of the primary disease, but also if the supportive care is missing. And that's why one of the very important tool ever developed in ICU care is this checklist called as FASTHUGSBID. It is like giving clinical hug to your patient twice every day. And in today's video, I am not only going to explain what is FASTHUGSBID, but also its fascinating history, recent modifications, and how to apply it practically during our ICU rounds. So friends, today's video is very important. You see this video till the end, and if you have come for the first time on this channel, then do subscribe this channel for more such clinical knowledge. So friends, without wasting much time, let's start the video. So the story begins in 2005 when one of the most respected intensivists, Professor Jean-Louis Vincent, he introduced the mnemonic fast hug. The idea was simple, that is to give a clinical hug to your patient at least once a day. The idea behind it was that no essential aspect of the patient care should be ever missed. And this fast hug, it includes feeding, analgesia, sedation, thromboprophylaxis, then head up position, ulcer prophylaxis, and glycemic control. Then in 2009, William Vincent and Kevin Hatton, they refined or expanded this mnemonic to FASTHUGSBID, and then they included many other parameters in the ICU care. And now this is the checklist, that is FASTHUGSBID, that is used worldwide. So it includes F for feeding, then analgesia, sedation, thromboprophylaxis, then head up position, ulcer prophylaxis, glycemic control, and these are the additions, that is spontaneous breathing trial, bowel care, indwelling catheter removal, and de-escalation. Now we will see one by one what all these means and how to assess them during the ICU rounds. So the first is F, and F stands for feeding. So here first question is NBM needed? Sometimes patient is posted for surgery or any procedure and patient is nil by mouth. So you have to confirm that the patient is nil by mouth. Or sometimes the procedure is over and patient is unnecessarily kept nil by mouth. In that case also you have to confirm that now nil by mouth is not necessary and patient can be feeded. So if the patient is feeded, you have to see if patient can be given orally or there is a Ryle's tube, or sometimes there can be some other feeding routes like gastrostomy or jejunostomy, etc. And you have to also see about the nutrition, like how much calories patient needs or how much protein patient needs. Early enteral nutrition is always preferred in ICU because it improves patient recovery. Now the second is A, and A stands for analgesia. So first you have to assess if patient needs analgesia. Sometimes patient is drowsy or patient is sedated, patient may not be able to communicate if patient is in pain. So here you have to first assess if the analgesia is needed, and for that various types of scales have been developed like CPOT. It stands for Critical Care Pain Observation Tool, or another is Behavior Pain Scale. So using these various types of scales, you have to assess if the patient needs analgesia. Then you have to decide what type of drugs and how much dose can be given. So various drugs like NSAIDs can be given, or opioids can be given. So this is analgesia. A comfortable patient recovers faster. Then the third is sedation. And here also you have to first assess the need, and for that also various types of scales have been developed like RAS. It is Richmond Agitation Sedation Scale, or there is also another scale called as Ramsey Sedation Score. So first you have to assess if the patient needs any sedation, or if patient is already sedated, you have to also see if that sedation can be reduced. Then various type of drugs can be used for sedation like midazolam or non-benzodiazepines like propofol, dexmedetomidine, etc. So here we have to see that patient is in comfort and patient is not in coma due to sedation. Now next is T, and T stands for thromboprophylaxis. Here also you have to assess if the patient needs thromboprophylaxis. Almost every patient in the ICU generally needs thromboprophylaxis, and here also there are various types of scales, but generally if the patient is in sepsis or patient is in trauma, patient of malignancy, post-op patients, these are the patients, they are at high risk of pulmonary embolism, and these types of patients generally require thromboprophylaxis. And then there are various types of methods that can be used for thromboprophylaxis. So the first is the pharmacological method. Pharmacological means here we use various types of drugs like low molecular weight heparin or unfractionated heparin. Then there are mechanical methods. Mechanical methods includes DVT pumps, and you can also use DVT stockings. So this is thromboprophylaxis, and it is important because the incidence of pulmonary embolism in ICU, it ranges from 0.5% to 18.7%. So thromboprophylaxis in ICU is very important. Now the next is head up position. The head end of the patient, it should be kept at 30 to 45 degree up. And this is important because it is helpful and it prevents many conditions. So it improves the respiratory mechanics, it reduces the risk of aspiration, and hence it also reduces the risk of ventilator associated pneumonia. So this was important, that is head up position. And then there is ulcer prophylaxis. So the patient who is in ICU, who is in sepsis or trauma, that patient is always under stress. And in stress, we know that hormone cortisol is released, and this leads to gastric ulcers. And hence the ulcer prophylaxis is very important, especially if the patient who are on steroids, they are at high risk of gastric ulcers and GI bleed. So in this case, you have to give ulcer prophylaxis. So you can either use PPI proton pump inhibitors or H2 receptor blockers. So this is ulcer prophylaxis. Then comes the glycemic control. In ICU, we do not want hypoglycemia, and we do not also want hyperglycemia, because if there is hyperglycemia, there is increased risk of sepsis, and also the patient's stay in the ICU increases. So here we have to maintain the sugar between 140 to 180. So if the patient is hypoglycemic, you can give patient dextrose, and if patient is hyperglycemic, you generally give patient insulin, either fractional doses or insulin infusion. So in this way, glycemic control is very important. Now comes all the extra additions to the FASTHUG mnemonic. So the first is spontaneous breathing trial. So for any patient who is on ventilator, we have to ask three important questions. First, can the sedation be reduced? Is patient is ready for spontaneous breathing trial, that is to reduce the ventilatory support and put patient on spontaneous breathing. And can patient be extubated? This is important because every unnecessary ventilator day, it increases the complication. So this is spontaneous breathing trial. Then comes the very important part of the ICU care, that is bowel care. Patient can either have constipation or diarrhea. If the patient is constipated, then you have to give various types of laxatives, and diarrhea is also very common in ICU because ICU patients receive a lot of antibiotics which can lead to diarrhea. So in that case, you have to use various type of antidiarrheal agents. This is important because constipation can worsen feeding intolerance, delirium, and patient discomfort. So it is mainly related to the patient discomfort. And in case of diarrhea, if the diarrhea is profuse, it can also lead to electrolyte imbalance. So this is about bowel care. Then comes another important aspect related to the indwelling catheters. So patient can have various types of indwelling catheters like Ryle's tube, CVP line, endotracheal tube, Foley's catheter, arterial line, invasive arterial line, etc. So you have to always see if they are needed for the patient or if they can be removed or replaced. In our ICU, in the drug sheet, we have this column. On this side, we have the name of the indwelling catheter, and then on this side is the date. So always we check at what date that catheter was put and what is today's date, and if that catheter has to be removed or replaced. And the last but not the least is a very important aspect of de-escalation. So here you have to see if there are any unnecessary antibiotics that are going to the patient and if they can be removed or de-escalated, or are there any unnecessary drugs that patient is receiving that we can stop, or if there are any catheters that are not needed for the patient now and if they can be removed. So in this way, we have seen what all is included in FASTHUGSBID and how to assess it during the ICU rounds. In our ICU, this is our monitoring chart, and in every duty, we have this FASTHUGSBID checklist. So as you can see, in the morning duty, this has been checked, and when a new RMO will come in the evening, he will also check like this. If feeding is checked, then F will be corrected, then A, S, T, then H, U, G, S, and like this. And also one who will come at the night, he will also check this checklist. Now we will see what are the various modifications in this checklist. Now in F, apart from the feeding, you can also add fluids. This is also the important aspect of ICU care. Then in sedation, you can add the spontaneous breathing trial, which was here. You can take it here, spontaneous breathing trial, and to that you can also add supplemental oxygen. Then with thromboprophylaxis, you can also add this temperature. That is, you have to see if the patient is having fever or not. Then in ulcers, I have done this too. Means apart from gastric ulcers, the pressure ulcers, that is bed sores, they are also important. And in that you can also add urine output. And here at S, we have taken spontaneous breathing trial here. So here in S, you have skin and eye care. So in this way, various modifications can be done and used in our ICU care. If you want to remember one thing from today's video, remember that ICU outcomes are often determined by small details done consistently every day. Before you finish your round, always ask, have I hugged my patient today? And this will improve your patient more than many expensive interventions. So friends, I hope that today's video was helpful to you. If it was useful, give it a like, share with your friends, and if you have come for the first time on this channel, then do subscribe this channel for more such clinical videos. See you in the next video. Till then, thank you.